Okay, so welcome back to those that had joined us for our first session for today, which was on pregnancy and neuromuscular disorders. And now in this next session, we'll be talking about family planning, genetics, and neuromuscular disorders. And so good afternoon and welcome to this session. Before I go into introducing today's topic and speakers, I wanted to mention that today's webinar is available in English and in French. So on your screen, you will see a globe icon for which you can select the audio in English or in French. I'll pass it over to one of our directors of mission, Marie-Hélène Bolduc, who will also explain this instruction in French.
Oui, bonjour tout le monde. Alors, merci d'être là pour cette deuxième conférence de la journée sur le thème de la parentalité ou la santé sexuelle. Alors, je veux juste vous informer que si vous voulez écouter la conférence en français, comme vous voyez sur l'écran, il y a une icône dans le bas de votre écran. Vous allez voir une icône en forme de globe terrestre. Vous allez cliquer là-dessus et choisir la langue de votre choix et vous entendrez tout le long de la conférence la langue que vous aurez choisie. Alors, merci beaucoup.
Thank you, Marie. All right, so we'll go ahead and get started. I should mention that we had a webinar earlier this year on Genomics 101, and it was a webinar done in conjunction and collaboration with the Neuromuscular Disease Network for Canada. And we're really grateful to have Kim and Lauren present at that webinar. It was called Genomics 101. We have a webinar report also available on that topic. And there was a lot of interest following that webinar to learn more about what is a genetic counselor? What do genetic testing really mean? Do I need to go in for genetic tests? And so we welcomed Kim and Lauren back, invited them back to give a webinar to help discuss these topics and answer some common questions. So I'm going to go ahead and introduce Kim and Lauren, and then I'll stop sharing my screen so they can share their presentation. Kim received her master's degree in genetic counseling from the University of Pittsburgh. She is currently the genetic counselor in the Pediatric Neuromuscular Clinic at the Hospital for Sick Children in Toronto. Kim is an instructor in the Department of Molecular Genetics at the University of Toronto. She is also a member of the Canadian Rare Disease Organization, Canadian Gene Cure Advanced Therapies for Rare Disease. She's a clinician researcher. She has worked on studies of the prevalence and natural history of congenital myopathies in individuals with RYR1 mutations. Lauren Brady, she received her master's degree in genetic counseling from Sarah Lawrence College in Bronxville, New York. She is a second-generation genetic counselor, and she has been working in the neuromuscular clinic at McMaster Children's Hospital with Dr. Mark Ternopelski since 2012. Welcome, Lauren. Welcome, Kim.
Thank you, Humira.
Okay, can everyone see the slides? Yes, perfect. Okay, so I'm Lauren.
I'm Kim.
Okay, so these are our disclosures, and yeah, we're here to talk today about family planning for options for neuromuscular disorders, and we're both genetic counselors. And as someone has already mentioned, today is Genetic Counselor Awareness Day. So that's a perfect opportunity to be talking about this. And this was not intentional to have it today, but it's sort of a happy coincidence. Now, do we have those polls?
We sure do. There we go.
We're just kind of curious to hear a little bit more about the audience today, which can help us a little bit with some of the topics that we talk about and what we can go into more detail with. And then also we were just curious to see how many people have, okay, so a lot of people who have a neuromuscular condition themselves, lots of other allied health professionals. And then we were also just curious to see how many people have seen a genetic counselor before. Okay, so a lot of people have and 80% haven't, only 20% have. Okay. So for those of you who have seen a genetic counselor, this might be a bit of a review, but for those of you who haven't, might be kind of wondering, what is a genetic counselor? What is genetic counseling? A genetic counselor, our main job is to assist with the ordering of genetic testing and also with the interpretation of genetic test results. We're basically experts in human genetics, and we talk with individuals and families about the natural history of those genetic conditions or congenital conditions, as well as the psychosocial and reproductive implications of a genetic diagnosis. So when we're talking about reproduction, that might involve a discussion about what is the risk of recurrence of that condition appearing again for a couple or in the family. What does that mean? You know, what does the inheritance pattern of that condition look like? What are some available testing options? Can we do testing during a pregnancy, before a pregnancy? And you know, what would the medical management look like if there was another individual to be born with that genetic condition in a family? So really, you know, the first step that we want to do as genetic counselors, you know, genetics professionals, is we want to be able to get a genetic diagnosis. We want to be able to figure out, you know, exactly at the genetic level where the genetic change is, and because that will give us information about what that means for that couple or that family. Right now, there is over 545 genes associated with various different genetic neuromuscular conditions. There is more being found every day. Some of those genes, depending on where the genetic change is in that gene, if it's at the beginning or the end, can cause different genetic neuromuscular conditions, or even can cause even a non-neuromuscular genetic condition. So it can be quite complicated. And so being able to really pin down exactly what the genetic diagnosis is will really allow us to talk very clearly about what the inheritance pattern would be, what's the chance of the condition appearing again, and talk about what family planning or prenatal diagnosis options would be available. Without that genetic diagnosis, a lot of that conversation is kind of very hypothetical. Right now, so there are there's three main inheritance patterns that we can see for genetic neuromuscular conditions. And I apologize if this is a trip down memory lane for people to do high school biology class. So for autosomal recessive conditions, everyone has 2 copies of every gene. They inherit one from mom, one from dad. With autosomal recessive conditions, we see that, you know, mom has a genetic change on one of her 2 copies of that gene, and like you can see here, and dad has the same thing. They themselves don't have that genetic condition because they're protected by the other copy of the gene, which doesn't have that genetic change. However, when they have children, the genetic change from mom can be passed down, as well as the genetic change from dad to the same child. And then that child who has a genetic change on both their 2 copies will have the condition. Okay. For this couple who are both carriers, for each pregnancy, there's a 25% chance for them to have a child with that particular neuromuscular condition. 50% chance of having a child who's a carrier, 25% chance to have a child who does not have the condition and is also not a carrier. In these situations, there is typically no negative health effects associated with being a carrier of the condition. An example of this would be spinal muscular atrophy. For dominant conditions, you only need to have one genetic change on one of your genes in order to have the condition. A lot of these times, this condition is inherited from one parent. So in this scenario here, mom has the genetic change on one of her 2 copies. She has the condition. So when she has kids, she's either going to pass on the copy that does not have the genetic change or the copy that does have the genetic change. So 50% of her children will have the same neuromuscular condition, 50% will not. So an example of that would be CMT1A, which I think you guys heard about if you attended the lecture before this one. With X-linked conditions, we're talking about the X chromosome, which again, back from biology class, are the X and Y chromosome are the ones that determine if you're a male or female. So women have two X chromosomes, XX, men have an X chromosome and a Y chromosome, XY. The two X chromosomes are identical to each other. The Y chromosome does not have a lot of genetic information on it. It really just has a bunch of genes that say make this person a male. So in these, with excellent conditions, mom can be a carrier of that condition. So it means that she has a genetic change on one of her two X chromosomes, right here. But she is protected by her other X chromosome. So she might have either no symptoms or maybe just very mild symptoms. Now, if she were to pass on that X chromosome, the one with the genetic change, to a male child, he doesn't have that second X chromosome to protect him. So he's going to have that condition, which is going to show more severe symptoms than what would be seen in a female. So an example for that would be Duchenne muscular dystrophy, for example. Now, not all genetic changes are inherited. We can see what we call de novo mutations, which basically means it's a brand new genetic change and it comes out of the blue. So in these cases, neither parent has a neuromuscular condition, neither of them are carriers, they don't have this genetic change. The genetic change appears for the first time in that child. So a lot of autosomal dominant and X-linked conditions can happen brand new. There is not always a parent who has the condition. Mom is not always a carrier. Change can happen brand new. And so for couples where this happens, there's about a less than 1% chance for them to have another child with that neuromuscular condition. The reason why we say 1% and or less than 1% versus 0% is because we just can't rule out the possibility that there's more than one sperm or more than one egg that has that genetic change. So I'm going to pass it on to Kim to talk about some family planning options.
Thanks, Lauren, for setting the stage for that. I think it's a great foundation for what we're going to talk about. So we'll go through, for the remainder of the talk, through all of the family planning options from preconception, so before a pregnancy, during a pregnancy, to after a pregnancy. And so we'll walk you through each of those options. Next slide. And we just want to emphasize that these are options, just as the word implies, that none of these tests are mandatory. So you may choose to opt out or decline any of these tests. And as many of you may be familiar with some of these tests as we go through them, some of these options are presented to all families, and some are really only presented in the context of certain situations or certain inheritance patterns or things like that. And some are just new technologies. So we'll give you the overview and kind of give you some of those distinctions. Next slide. So there are many different reasons to consider different family planning options, and they're going to be unique to each family. So we're going to walk you through kind of some of the reasons we've come across with some of our patients. So some families will say, I don't want to have another child with this condition, and that can mean different things for different families. And each of these decisions are going to be rooted in personal and cultural and religious beliefs. And it's really important, and we respect all of those decisions and want to help families make the informed decisions and what's going to be best for them. And it may be different from family to family, but also pregnancy to pregnancy. So in this case, when we're talking about not wanting to have another child, it could be interpreted many different ways. It could mean that if the condition is identified during a pregnancy, a family may choose to end the pregnancy, or it may be to consider preconception options like the combination of in vitro fertilization and pre-implantation genetic testing, which we'll go through shortly, or using egg or sperm donors, or considering adoption. So it can mean many different things to many different families. Next slide. Some families want to pursue these options because they just want to be prepared for when the child's born. As many of you know who have been through this process before, it's a long journey to adapting to a diagnosis, even if it's something that's been in the family before, but it may be new to this pregnancy or just at that time. And so it may take some time to adapt and even potentially grieve the loss of the expectations of what you expected for that pregnancy. So some families just need that extra time to be able to adapt. And next slide. And another reason can also be to prepare for delivery. So many neuromuscular conditions, things like congenital myotonic dystrophy or myotubular myopathy, there may be difficulties breathing right at the time of birth or during delivery. And it's important to consider a hospital delivery. A home delivery or a delivery outside the hospital may not be an option, and you may need specific healthcare workers to be there for the birth to deal with any needs that arise. So that may be another reason to consider some of these options. Next slide. All right, so like I said, Lauren and I will take you through kind of the whole process. So starting before pregnancy, what options are available, what are options that are available during a pregnancy, and those that will be available after birth. And I think it's important as we go through each of these, the one thing to also keep in mind is that inheritance pattern that Lauren had brought up, those de novo or new genetic changes, that many of these screening methods and these diagnostic tests, we can't screen for every single genetic condition. So we typically focus on the neuromuscular condition that's running in the family. We can also look for chromosomal conditions, but we can't always prevent or detect every genetic condition. So none of these strategies are going to prevent or look for every genetic condition. So the first option that's available before birth or before pregnancy is the combination of in vitro fertilization or IVF with pre-implantation genetic testing. And we're going to focus on these for monogenetic conditions. And that just means it's a genetic condition that's due to a change in one gene, not multiple genes. And so there's kind of three main steps to this process. So it begins with IVF, where the egg and the sperm are combined in the lab. The embryos are then screened for the neuromuscular condition that's been identified in the family. And this is where it's really important to have that confirmatory genetic test in another family member and an idea of the inheritance pattern. And then only the embryos that are found not to carry the genetic change that's associated with the condition would be implanted. So this is a way to kind of prevent the condition from happening in future pregnancies. And this may not be an option that may be right for every family, and there's lots of considerations to be thinking about when deciding if this is the right option for you. So the main thing that most families ask about is cost. So this can often be a very costly procedure. So IVF itself can be quite costly. And here in Ontario, we do have funding for one cycle of IVF through our provincial funding. So that is something that is available to patients here, but it may not be available in all provinces or territories. And there are often many out-of-pocket costs. So even though some of the costs with IVF are covered for some of our patients, the PGT, the screening of the embryos is not covered. So there can be significant out-of-pocket costs. And so that's something to discuss when deciding about this option. Additionally, if there is funding available to help with some of these costs, it can take a long time to access these funds. So here in Ontario, I believe it's about a year-long wait or sometimes even longer to be able to access this funding. So when you're considering this option, even if it's something you may not pursue in the end, you may want to consider a consultation pretty early on in the process so you can be put on the waiting list for that. And then the other main thing to consider is who may need to be involved with this. So the screening of the embryos is done, and the probes that are needed to do that are often very specific to a specific mutation or to a specific family. There can be multiple markers that they look at. And so these have to be designed each time. And so there may be samples needed from multiple family members outside of the immediate family members or any others to really help determine whether or not the embryos carry the change so that they can be implanted without it. So this may be a discussion that you may want to consider with your other family members and whether you're ready to discuss the genetic condition that's running in the family and the inheritance and the possible risk to other families, but also would they be willing to contribute samples if needed to pursue this option. So it's a long discussion and things that you'll want to consider when deciding if PGT is right for you. I also just want to mention there are a couple other different types of PGT that you may come across in doing any research on this. So we're focusing on PGT-M, which is for a monogenetic condition, but they can also screen for chromosomal changes as well. So extra missing chromosomes or rearrangements. So pieces of chromosomes that are not in the right places. They are able to do that as part of this test as well. And sometimes they can be done in conjunction, or sometimes they can do the screening just for that. So that's everything on PGT. And then there's one other option for preconception screening and testing. So also the consideration of sperm and egg donors. So depending on the inheritance pattern and the infected members in the family, this may be an option to think about. And this would be done through a fertility clinic. And it is important to note that many donors are screened for kind of generic genetic conditions to see if they're carriers. But again, it's not exhaustive and would not look for every genetic condition. All right, now we're going to switch gears and talk about testing options that are available during a pregnancy. So we want to really make sure that we make the distinction between the two different types of tests that are available during a pregnancy. And so there are really screening options and diagnostic testing options. And screening options are meant to really screen for different conditions and give you a risk number. So is there an elevated risk for a certain condition? These do not give a yes or no answer and typically require additional testing afterwards to confirm whether or not the baby truly has the condition versus a diagnostic test, which will give you a yes or no answer and will be much more definitive. And so we'll go through each of those. So I'll start off with a test that may be familiar to many people. So this is the Provincial prenatal screening. So this is done during the first trimester of the pregnancy. And in Ontario, we have the Enhanced First Trimester Screening, or EFTS. And this is a combination of both blood work and an ultrasound that's done around 11 to 13 weeks of gestation, and is really screening for two main conditions. So trisomy 18, which is 3 copies of chromosome 18, or 3 copies of chromosome 21, which is most commonly known as Down syndrome. And the blood work that's done from mom usually measures about 3 to 4 hormones or proteins in the blood. And then on the ultrasound, you can see in the picture here that we specifically look at the fluid at the back of the neck of the baby, and this is called the nuchal translucency. And we know that an increased size in the nuchal translucency can be associated with chromosomal conditions or heart conditions. So we take that measurement and put it together with the markers in the blood from mom and are able to give those risk numbers for trisomy 18 and Down syndrome. And again, this is a screening test, so it only provides a risk number. It's not a diagnostic test. So there can be false positives, there can be false negatives with this test. Next slide. And then the other prenatal screening option is non-invasive prenatal screening, or NIPS. And this is a relatively new technology. And it's usually done, it's a blood test from the maternal blood sample that's taken around 10 weeks of pregnancy. And we can actually isolate the fetal DNA that's circulating in the maternal bloodstream. And again, this is a screening test, and it's really meant to look for chromosomal conditions. So it's screening for trisomy 13, 18, and 21. And we can also get a look at the sex chromosomes. And some of the indications to consider this test is if there's a screen positive for the first trimester screening, or to look at the fetal sex for X-linked conditions. So for example, for Duchenne muscular dystrophy, which we know typically affects boys, if the pregnancy is found to be a female, invasive testing could be avoided if we're able to determine sex with this test. And more recently, we've been able to use NIPS to look for monogenic disorders. So for example, in a recent family that I worked with, they had a previous child with SMA, and they chose in a subsequent pregnancy to pursue NIPS. And through that test, they did find a high risk for the baby being affected with SMA. They then chose to have diagnostic testing, or a CBS, which Lauren will go through shortly, to confirm whether or not the baby had SMA, and the CBS came back saying that the baby was a carrier of SMA. So the NIPS was picking that up, but wasn't able to detect that for sure. So it really just highlights the reason that this test is still considered a screen. It is not a diagnostic test. And so those diagnostic tests are typically needed afterwards to confirm. And I think that's it for the screening options.
Okay, so I'll pick it up from here to talk about the diagnostic testing options. So these are the ones that do give the yes or no answer. So there's two of them. So in these cases, there is a pregnancy already. And the first testing opportunity comes up between 11 to 14 weeks gestation. This is the chorionic villus sampling, or CVS, that Kim was mentioning. Basically, with this test, they're doing the genetic testing on the placenta, because the placenta is genetically identical to the baby. So depending on where the placenta is located, if it's sort of at the back, they might need to go into the cervix to get a sample. If it's located kind of up and near the front, they can use a needle into the abdomen to take out a little piece. Because it is an invasive procedure, there is always a chance of complication, something like infection or excessive bleeding. And these complications could lead to a pregnancy loss. They estimate that about 1% of women who go through a CVS procedure, or 1 in 100, there would be a pregnancy loss shortly after the procedure is done. The other 99%, there would be no pregnancy loss. After this procedure is done, it takes about 2 to 4 weeks to get the genetic test results back, and they do provide the yes or no answer. And oftentimes when they do these tests, they will also look for things like the chromosomes, like things like Down syndrome and the X and Y chromosome, so female or male. So you get all that information as well, and that is all diagnostic. The other option for prenatal testing comes a couple of weeks later, between 15 and 20 weeks gestation. In this case, the genetic testing is done on the amniotic fluid, so the fluid around the pregnancy. And in that fluid is floating skin cells, and that's where they're able to get the DNA from. This test is very similar to the CVS, where they use the needle to go in through the abdomen. So not through the belly button, through the abdomen, and they just take out a little bit of the amniotic fluid. This test is considered to be safer, lower chance of pregnancy loss or complications, but 1 in 400 cases, there's a pregnancy loss. Amniocentesis is considered to be a little bit more available than CVS. There are more places across Canada that do amniocentesis, and very similar timeline for genetic results. It takes about 2 to 4 weeks to get these results back. And again, provide the yes or no answer for the specific genetic neuromuscular genetic condition that we're talking about, as well as looking at the chromosomes and the sex chromosomes. So a lot of the conversation around these two procedures comes around the pros and cons of each, and which might be better for a family. And a lot of it I find comes down to timing. So a couple who might be leaning towards terminating a pregnancy if if the result shows that it has the same neuromuscular condition, might be more likely to do the CVS because it happens earlier on in the pregnancy. You get results back earlier, and so it is easier to do a termination earlier. couples who are more looking towards getting that information for planning for the delivery or just to have that information earlier in the pregnancy might lean more towards amniocentesis. It does happen a little bit later on, but is considered to be a safer test. But it's totally up to the couple, and we review all the different options. But not all testing has to be done during a pregnancy. We also can do testing after a baby is born. So really this only does apply to conditions that do appear in childhood. So things like SMA or Duchenne muscular dystrophy. We are not likely to do testing for adult onset conditions. So something like facioscapulohumeral muscular dystrophy is something that we wouldn't do right after a baby's born. The genetic testing can be done on baby's blood or even cord blood, so which is the blood in the umbilical cord after baby's born, or it can always be done a little bit later in infancy or childhood, kind of depending on, I guess, the conversation, what's going on. In these scenarios, genetic results can come back pretty quickly in about 2 weeks, or they might take a little bit longer, possibly up to 2 months, and again, provide that yes or no definitive answer. The other thing that we did want to mention is that all babies who are born in Canada, in all provinces and territories, when they're born, go through something called newborn screening. And some of you may or may not be familiar with this, but basically all babies, they have their heel pricked when they're about 1 day old. It's put on a filter card, kind of like you see here, and it's sent off to be screened for a bunch of different conditions, some of which can include sickle cell anemia, cystic fibrosis, different metabolic conditions, critical congenital heart disease. The list really depends on different provinces, so different provinces will have different things on their list. Most recently, with the neuromuscular perspective, spinal muscular atrophy has been added onto the newborn screening list here in Ontario, but has not yet spread to any other provinces or territories in Canada. Basically, the idea of newborn screening is that if there is early detection of one of these conditions, they can do early treatment, which they have proven leads to long-term benefits for these particular conditions, and that waiting would be detrimental. But again, it's a screening test, so if there's ever a screen positive, there's always additional confirmatory testing that is done afterwards. So, so I know, so that wraps up most of our conversation about the different testing options. I know only 20% of people have seen a genetic counselor based on that poll earlier. So for here in Canada, if there is anyone who is interested in seeing a genetic counselor, can use this tool on the website for the Canadian Association of Genetic Counselors, or CAGC, to look for a genetic counseling clinic nearby. There are some neuromuscular clinics, like the one where I work at McMaster with Dr. Tarnopolsky, or the one that Kim works at Sick Kids, where there is a genetic counselor already there. And so if you are a patient of that clinic, I guess we would be your genetic counselor. But for people who live elsewhere, would go to a different clinic. And so at this point, we can open it up to some questions.
Thank you so much, Kim and Lauren. I do see some questions that came in right now live, but also ahead of time. Maybe I'll start with the ones that came in ahead of time. An individual had asked, they had done genetic testing and it came back, well, what they noted was inconclusive. So they're asking, well, when do I go back? What's that time frame that I wait and then I go back to seek more answers? Any suggestions for that person?
Yeah, I would say usually we say about, check in after a year, 2 years, because I guess the question is, was it inconclusive because there was a genetic change in a gene and they weren't sure if it was significant or not, because not all genetic changes are disease causing, or did they call it inconclusive because there's a neuromuscular condition but they didn't find anything, so obviously there's a gene that they maybe haven't discovered yet. So our knowledge of these genetic variants that are found gets updated all the time. We find new genes all the time. So it definitely is worthwhile to check back in, but I would say probably after a year, 2 years.
Excellent. That's great. The other question was that they were really encouraged to see SMA newborn screening being added in Ontario. And they were wondering if there was any insights about whether there would be other neuromuscular diseases that would be also added to newborn screening panels. Specifically, this person is interested in DMD, if Duchenne muscular dystrophy could be detected on a newborn screening panel. So maybe the question is, could it be detected is one part of it. And then any insights on whether that will be added in the future.
Yeah, that's another great question. I do know some places in the world have included Duchenne muscular dystrophy on their newborn screening panels. I haven't heard of anything coming down the pipeline in Canada yet, and Kim, maybe you can comment on if you've heard anything either. I'm not sure for the reason why it's in some places and not others. I think it might come down to the fact that we haven't yet identified a drug, like we have with SMA, that has really shown to have, a really strong improvement on long term for boys with Duchenne as of yet. But Kim, maybe do you have anything else to add to that?
Yeah, so I'm not aware yet of it coming to Canada yet, but certainly there have been quite a few research studies, I know in the States and I think in Europe as well, who have looked at trying to detect DMD on newborn screening. And usually it's done by looking at the CK level first, and they kind of have a cutoff there and are able to do testing, but it's a little bit more complicated than the testing that's done for SMA. And like Lauren said, there's not a treatment that we could initiate in infancy that has been shown yet to kind of change the natural history of the disease. But there's a lot going on, as many of you know, for Duchenne research. And as those therapies go through clinical trials and get approved, I think that's likely to change.
Very good, thank you. Another question that came in is an individual who has limb-girdle muscular dystrophy is wondering, her brother wants to plan for a family with his fiance, and the fiance has a cousin with CMT. Should they both get genetic counseling done, or is it just okay for her brother to go and get tested?
Yeah, I mean, we would definitely see somebody with that family history, like on both sides, and we would definitely talk about both sides of the family is testing needed for that couple. But for that couple, the most helpful thing that they could do would be if these people that the CMT and limb-girdle have a definitive diagnosis, to bring a copy of those results into the appointment so that we can know exactly what we're testing for and give that yes or no answer.
Very good, thank you. Another question that came up is, would CMT be tested for in a screening? Could you test for CMT? I know you both addressed this, but maybe we could talk about CMT options or options for screening for CMT. Sharko Marichu.
Yeah, so it's again really important for the type of CMT and that the genetic cause is known. And depending on which test is being pursued, it may be something that could be detected. It's not going to be something that would generally be screened for. So for example, in the first trimester screening, they wouldn't be looking for CMT as part of that. That's really targeted at those chromosomal disorders. But some of the other options where they're looking for a specific genetic condition, it may be possible. I think the other thing to throw out there too is that it may be different disease to disease. So some things, depending on, so for example, for PGT testing, they're testing the embryos at a very early cell stage, and they're trying to take the cells that would eventually become the placenta, and they have very limited DNA that they can deal with. So some genetic tests aren't really able to be done with that limited amount of DNA. So sometimes there may be some genetic conditions where they aren't able to do that test. So it's important to talk with a genetic counselor and walk through the potential options that would be available and working with the different labs to see whether it's feasible or not.
And this is related. We see one in the live Q&A box. An individual who is the only one who tested positive with CMTX1. Her sisters were never tested, and she has nieces and nephews now. Should they be tested?
So, I mean, they're definitely eligible for testing. We would definitely see them, but we're not really the ones who kind of should say, you know, yes, they should, or no, they shouldn't. In that scenario, I think it would sort of be up to the parents of those individuals on, you know, whether or not they want them tested if there were any concerns. But of course, we're happy to see them if they're interested.
Very good. I'm going to pass it to my colleague Marie-Hélène, who will ask you some questions that came in French, and you'll hear the translation as well.
Alors, la question est, puis-je revoir l'image de la transmission génétique lorsque la mère est positive et la gravité augmentée lorsqu'il y a un fils de toucher? Et puis-je connaître, deuxième question, puis-je connaître l'échelle des CK pour la dystrophie musculaire oculopharyngée? Je pourrais éventuellement reposer la deuxième question. Avez-vous entendu la question?
We heard the question. Lauren or Kim, do you want any clarification on those two questions?
Yes, you could repeat it again.
Okay. Can you hear it in
Yes.
English?
Yes, yes.
In French?
I think I heard it in French. So
I only heard it in French as well.
Yeah, I caught half of it, but I not the whole.
Okay, so I will try to ask it in English.
Okay.
So can I see again the slide where you see the genetic with when the mother is a carrier?
Huh?
I think this is the one, and is it worse when you have a son affected?
Yes. Yeah. So because the boys are more affected, when women are carriers of this condition, so they have the genetic change on one of their copies, one of their X chromosomes. They don't have the genetic change on the other, and so the other one kind of protects them. You know, all the genes on that X chromosome are working fine, and so it does protect them and they don't show symptoms. But because the Y chromosome doesn't have those same genes, when a boy inherits that X chromosome with the genetic changes on it, they don't have that other X chromosome to protect them. So that's why they do show more severe symptoms, and boys are more affected. So like Duchenne muscular dystrophy, CMTX, all those conditions will show up more in boys than they will in women.
Great.
Okay, and the second question was, and I'm not sure in English, but can I know what is the CK for OPMD? Number of CK.
Are they asking if like the CK is usually normal or high for OPMD?
Perhaps a range for CK values?
Yeah, they want to know the number.
That's a great question. You know what, CK is not usually something that we order in people with OPMD. We usually just order the genetic testing. So I don't really think of the CK as being something that's highly important for that particular condition. So I don't really, actually off the top of my head, I don't know what the ranges are, I'll be honest.
Okay, thank you.
That's great. Another question that came in is whether FSHD is a monogenetic condition. Would it show up in testing of an embryo?
So yes, it is a monogenetic condition, but it's a bit of a complicated one because not only is there a change, it's a repeat disorder. So we see a contraction on chromosome 4, and then you also have to have a haplotype associated with that that will cause the disease. So there's kind of two pieces to it. They're on the same chromosome that we look at. So it is a monogenetic condition, but it's one of the complicated ones. And that one, I'm not sure for prenatal testing and PGT if they're able to do that, because it is a specialty test that you have to do testing for that. Do you know, Lauren?
I do know. I think that they can find it. So when they're setting up the test in the family to do PGDM, I think that they are able to do linkage to kind of set it up so that they can figure out whether or not the embryo would or would not have FSH, muscular dystrophy. But don't quote me on that. I think it has been done. I know it's one of the conditions where it's not typically done for. I do know that at least here we have a lab in Ontario here that does the genetic testing for FSH. They will not take prenatal samples, but there is a lab in the US that does.
Very good. A question that came in is, if a fetus is found to have effective genes for neuromuscular disorders, is there a way to manipulate or treat the effective gene in the fetus before it's born? Any insights on whether that is possible or has happened?
Not yet, unfortunately. We're not able to go in and change the genetic code as of yet. That's something obviously people are looking at as a therapy, because if you could go in and fix the genetic change, and that would solve a lot of things. And as far as treatment for fetuses before it's born for neuromuscular conditions, I'm not aware of any. Kim, are there any that you can think of?
Not that I can think of. I think probably the thing that comes to mind for most people right now is CRISPR. So that's the gene editing technology that's available. But really, we're still exploring that in many different conditions and some neuromuscular conditions as well, but not yet at the fetal stage.
Mm-hmm.
Another question that came in is it common to have a misdiagnosis? They didn't say what they were diagnosed with previously, but they were then diagnosed with limb-girdle muscular dystrophy. And so there was just some frustration in that misdiagnosis, and they're wondering, how often does that happen where someone has another disorder and then it turns out they have limb-girdle muscular dystrophy?
I mean, it definitely can happen for sure. There could be other conditions that maybe look like limb-girdle muscular dystrophy, and so maybe a doctor thought it was that, or maybe the initial genetic testing was inconclusive, maybe pointed to something else, but with further knowledge, we ruled that out, and then more genetic testing became available, and then we were able to find that type of limb-girdle. There's a bunch of different scenarios, so I will say that it definitely can happen.
Great. There is a question about if a male with a neuromuscular condition has a daughter, what is the likelihood or chance? I would imagine that would depend on likelihood that the daughter would be a carrier, I should say. Would that depend on the neuromuscular condition? Yeah. Okay. And then another question that I wanted to ask, and I think you've touched on it, is for FSHD, could that be detected on newborn screening tests? Have you heard of whether that was detected on newborn screening panels yet?
No.
Not aware of that yet.
FSHD is so complicated on a molecular level, even in adults who appear to have features of FSH. That's not a condition that I would ever, and also because it can be late onset, that's the condition I don't think is ever going to really be unless there was a clear treatment found, is going to be a candidate for screening, for newborn screening.
A parent had messaged as saying that if they choose to have their children tested, will they be discriminated against in the future? Or what are some things you talk to families about when making that choice of testing their children?
It's a really good question, and something that comes up quite often. So one of the great things, at least in Canada, and actually there is a law in the US as well, that does help protect against these types of discriminations, but there are obviously limitations to these. So it really protects from having to disclose genetic testing results to an insurance company or things like that. But every law is not perfect. And so there are some exceptions and things that are not covered. So things like life insurance or other things, you don't have to disclose the genetic testing results, but they can still ask about family history. And once you go to clinics and kind of act on any of the genetic testing results, then those things may need to be disclosed at a later point. So while there are protections in place to help families from having to disclose that information, it's not perfect in every case. And so something that we talk about all the time is that if families are considering getting additional life insurance or disability or things like that, to consider doing that before doing the genetic testing, just because there's nothing to disclose at that point. That information isn't known. So it's something certainly to be aware of.
Very, very important, very helpful. Thank you, Kim. Lauren, you shared a slide at the end in terms of, I believe, how to find a genetic counselor here in Canada. Do you know if there's a similar version of that type of slide or information for individuals in the US? We have one person on the line who has FSH and they're in the US and they'd like to learn more about getting genetic testing there.
Yeah, definitely. So in the US, they have the National Society of Genetic Counselors, or NSGC. They have a similar search tool on their website. For FSH specifically, there's also a group in the US, I think it's the FSHD Society as well. They might also have a list of places where you can go to access genetic testing.
Wonderful. Marie-Helene, any questions from you before I wrap up our session for today?
No, no more French question. I was just answering in the chat, so that's okay.
Beautiful. Well, thank you so much to Lauren and to Kim for a really important, informative talk. Very clear presentations that helps to address the questions on what is a genetic counselor, why it's important to get tested, the things you can do pre and post. So that is very helpful. I welcome you all to attend our next session at 2 p.m. Eastern on sex, sexuality, and neuromuscular disorders. A recording of this webinar will be made available to our MDC YouTube page. And I would like to thank Roche, PTC, and Biogen for supporting education initiatives like this one and for their ongoing collaboration with MDC. Thank you all again. I hope to see you guys very soon for our next webinar. Thank you so much, Lauren and Kim, for an excellent presentation.